Good afternoon, respected teachers. I am Dr. Kunal Waghela, third year respiratory medicine resident in NIMS Medical College, Jaipur. So my today's paper presentation on mounier syndrome. So I am beginning with my presentation on 70-year-old male patient presented in our emergency department with shortness of breath, cough which is increased since 2 days. Patient have smoker and farmer by occupation with background of COPD. On examination, we found that his saturation was 94, BP was 120 by 80, pulse was 110, and respiratory rate was 21. On chest examination, we found that his bilateral rhonchi with clubbing are present. We further evaluation done by hematological and some radiological findings. So ESR was 76 mm per hour. Sputum AB found to be negative. So there is some hematological parameter. We found there is hemoglobin was 10.5 due to chronic respiratory illness. So we order about chest X-ray. We found there is right-sided pleural involvement or pleuroparenchymal infection. Here we found there is any pleural base opacity is found. So further evaluation done by CT scan, we found there is right-sided lower zone irregular homogeneous opacity. So our diagnosis was query infection, query tubercular etiology or any malignant etiology as far as age is concerned. So here you clearly see there is some sort of tracheomalacia, tracheomegaly was also found. So we discuss with our radiological colleague. They are saying some sort of significant tracheal diameter are increased. So we found we done fiber optic bronchoscopy. We found there is while inspiration airway lumen size is normal, but while expiration some sort of collapse is seen. So we send it ball fluid for AFP, KOH and malignant cytology, which was negative. Based on above clinical, historical as well as radiological finding, we label as mounier syndrome. So patient was treated conservatively till date and there is no exacerbation or no complication found, and patient was symptomatically better and regular follow-up in the respiratory medicine department. So our discussion based on mounier syndrome. So it is airway abnormality with loss or reduced airway wall elasticity, specifically found on trachea and bronchi. So there is a classification due to adult tracheomalacia. It might be due to genetic or it might be idiopathic, like our case mounier syndrome. Secondary acquired was post-traumatic emphysematous chronic inflammation or might be due to external compression. So similar case was also noted in 2017 with same clinical background and same criteria. They are diagnosed with mounier syndrome. So my conclusion was tracheobronchomalacia, usually progressive disease and worse with infection like COVID-19, and they are reducing quality of life. This is my reference. Thank you so much.